Hi, everyone. Today, I am going to continue on our discussion about prostate cancer and would emphasize on a few things that are, again, for stratifying risk group for each patient to individuals' their treatment. The first one is TNM staging. Second one is risk stratification in 6 groups of very low to very high risk groups. And then I will introduce to you what is called a nomogram that we use in prostate cancer, again, to stratify risk and direct our treatment individually based on the disease itself. And then I would finish the discussion with discussion about 3 tests that are called molecular assays. And again, they would biologically stratify disease for us and help us further to individualize treatments based on biology of each cancer. As you may know, for almost all of cancers, we have what is called a TNM stage. T stands for tumor, N stands for lymph node, M stands for distant metastasis. And each one is different. So is staging for prostate cancer. So for prostate cancer, like many other cancers, we have T1, T2, T3, T4. And each one of these have their own subcategories. T1, which is the earliest T staging, would be divided into T1A, B, and C. T1A and B only apply to individuals whose cancer has been detected incidentally. For example, many gentlemen suffer from BPH, benign prostatic hypertrophy, and they might undergo surgery to relieve their urinary symptoms. But incidentally, when pathologist looks at their prostate, which has been removed now, they discovered there was cancer, and patient or their doctor did not know about it before surgery. Now, if pathologist discovers cancer in less than 5% of the tissue removed, that would be called T1A. If it's in more than 5% of the tissue removed, that would be called T1B. T1C, on the other hand, is perhaps in countries where patients are compliant with doing their prostate cancer screening, perhaps that would be the most common and the ideal way of detecting prostate cancer. And that is based on what we call rising PSA. So for prostate cancer screening, as you may know, a gentleman, depending on their family history, if they are in average risk group, they start prostate cancer screening at age 50 by doing a blood test once a year for PSA, prostatic specific antigen. And their doctor keeps an eye on it as long as it remains within the normal range. No further action is required. But if their PSA starts going above the normal range, that may result in getting a biopsy. So if the biopsy was done and it was proven that patient has prostate cancer, that would be staged as T1C. For T2, we have T2A, T2B, and T2C. T2A if you imagine that prostate cancer has two sides or two lobes, as we call it, if up to half of one lobe, one of the two lobes, is involved with cancer, we call that T2A. If more than half of one side of the prostate is involved, we call that T2B. T2C applies to when cancer has been detected in both lobes or both sides of the prostate. Now, T3 is when the cancer has begun to come out of the prostate gland itself, but hasn't gone too far. So if you imagine like an orange that has a peel, now if you imagine that prostate gland has what we call a capsule, if the cancer microscopically begins to come out of the capsule, if this is capsule, the cancer start coming out, that is called extracapsular extension. And that would result in staging T3A. On top of prostate gland, we have these glands called seminal vesicles. If the cancer goes into one or two seminal vesicles, then it would be staged as T3B. T4 applies to scenarios when the cancer has involved or invaded the surrounding organs. And hallmark of that often is what we call fixation, meaning that when I do a digital rectal examination with my finger, I can move the prostate gland. That we call mobile. Now, if the cancer has come out of the prostate and has invaded rectum, bladder, sphincter, pelvic muscles, pelvic wall, then prostate gland itself would not be mobile because it is kind of attached, anchored to the surrounding organs. So with the finger, when we examine it, we feel that prostate is fixed. It is not moving. And that is usually a sign of stage T4. Stage T4 is different from stage 4 overall. You might have heard of stage 4, and that may trigger that, oh, cancer has a spread or is really advanced. Based on T, N, and M staging, we then stage the cancer to a stage 1, 2, 3, 4. And often stage 4 means that cancer has a spread to distant organs, not the organs adjacent to the prostate, such as rectum and bladder and sphincter and pelvic muscle, but bone or somewhere else. That in the staging of prostate cancer, we have M1A, M1B, and M1C. M1A is when the cancer has a spread to the lymph nodes in the pelvis. M1B is when the cancer has a spread to a bone. M1C is when the cancer has involved another organ. And why are we distinguishing this? Is an M1 just bad enough? Why are we subcategorizing it to M1A and B and C? Because obviously, if somebody has lymph node involvement, but they do not have cancer in their bone or other organs, their prognosis is better. Now, when it comes to distant metastasis, in prostate cancer specifically, if there is only involvement of bone or bones, the prognosis is worse than having lymph node metastasis, but is better than having cancer in organs other than bone. For that reason, we subcategorize M to M1A, B, and C. Now, based on the factors that we discussed last week and what we just discussed, then we, based on research, we have created 6 major groups, risk groups for prostate cancer. And that includes very low risk group, low risk group, favorable intermediate risk group, unfavorable intermediate risk group, high risk, and very high risk. And I would tell you what are the factors that would make a cancer very low risk or very high risk. So for very low risk, all of the following factors have to be present. T1C, to refresh your memory, that is a cancer that has been detected purely based on rising PSA. It must also have grade group 1. To refresh your memory, we discussed that based on Gleason score and based on predominant primary and secondary patterns in the pathology reading prostate cancer, we divide grade groups to 1, 2, 3, 4, 5. 1 is when we have a Gleason score of 6, which is 3 plus 3. 2 is when we have a Gleason score of 7, but the primary pattern is 3. So 3 plus 4 equals 7 will be grade group 2. We have grade group 3 when the primary predominant pattern is 4. So it is still 7, but it is 4 plus 3. That becomes grade group 3. Grade group 4 is when the Gleason score is 8, any combination of 4 plus 4, 3 plus 5, and 5 plus 3. And grade group 5 would be when we have a Gleason score of 9 or 10. And 9 could be 4 plus 5, or could be 5 plus 4. 10 is 5 plus 5. So going back to the very low risk group, we want to have T1C. We want to have grade group of 1 or Gleason score of 6. We want a PSA that is less than 10. We want a PSA density, and we discussed that last time, that based on the volume of prostate, we can calculate, based on PSA and volume of prostate, we can calculate PSA density. PSA density less than 0.15 is one of the factors that should be in these factors that then we designated as a very low risk group. And the last one is less than 3 positive cores. What is a core? Generally, when we do a biopsy prostate cancer, we obtain 12 biopsies. These are using needles that are large. They have a hollow inside. And when the needle is inserted and the tissue is extracted, the tissue comes like a tiny cylinder. We call that a core. When we do 12 biopsies from different areas of prostate, then we have 12 cores that would be submitted to a pathologist. And pathologist looks at each core individually and not only gives a grade to Gleason score, it also gives us physicians, radiation oncologists, urologists, the information that what is the percentage of each of these cores that is involved with cancer. So this particular factor, in order to belong to very low risk group, less than 3 of cores have to be involved, and none of the cores can have more than 50% involved. So if all of these factors are present, we designate that cancer to be a very low risk group. Now, The second category is low-risk group. For low-risk group, again, all of these factors have to be present. It could be a T1C or a T2A. T2A is when less than half of one of lobes or one side of prostate is involved with cancer. Grade group still can to be only up to 6, Gleason score of 6, 3 plus 3. And PSA still must remain less than 10. Now, for intermediate risk, we have some intermediate risk factors, and then we subcategorize it to favorable and unfavorable. What are the intermediate risk factors? The T stage could be T2B up to T2C, meaning T2B was when we have more than half of one side involved. T2C is when both sides of the prostate are involved. So these are considered intermediate risk factor. Grade group could be 2 or 3, meaning that Gleason score is 7. For grade group 1, it is 3 plus 4 equals 7. For grade group 3, it's 4 plus 3 equals 7. The other intermediate risk factor is having a PSA between 10 and 20. Now, what is a favorable intermediate risk prostate cancer? It is when grade group is either 1 or 2. That is, Gleason score is either 6 or it is 7, provided the predominant primary pattern is 3, meaning that Gleason score has to be 3 plus 4 equals 7. It cannot be 4 plus 3. And also less than 50% of biopsy cores are positive. So if these conditions apply, then we put that prostate cancer into what is called a favorable intermediate risk group. Now, what is unfavorable intermediate risk group is when we have a grade group of 3. That is, Gleason score is 7, but the primary pattern is 4. So Gleason score is 4 plus 3 equals 7. And more than 50% of biopsy cores involved. Now, moving on to high risk group, one of the high risk factors must be present. Either T stage is T3A. T3A was when the cancer was coming out of the capsule, and we call it extracapsular extension, and that is T3A. Or grade group is 4 or 5. And as we discussed, 4 is Gleason score of 8, and 5 is Gleason score of 9 or 10. And PSA if it's more than 20. So any of these factors would put disease in the high risk group. Now, what is very high risk group is at least one of the following factors is present. If the T stage is now T3B or T4, if you recall, T3B is when the cancer has involved the glands on top of prostate gland. They're called seminal vesicles. That makes the cancer T stage to be T3B. Or it has involved the adjacent organs, such as rectum, such as bladder, sphincter, pelvic muscles. That makes the cancer to be a T4. So if it's T3B or T4, it's suddenly very high risk group. If it's Gleason score, any Gleason score, when the primary is 5. So you can have Gleason score of 8, which is 5 plus 3. You can have Gleason score of 9, which is 5 plus 4. Or you can have Gleason score of 10, which is 5 plus 5. Any of those would make the cancer to be very high risk. If there are 2 or 3 high risk features present, as we discussed, high risk features were 3A, T3A, Gleason score of 4 or 5, PSA more than 20. And if more than 4 cores, more than 4 biopsy cores, they have Gleason group of or grade group of 4 or 5. So what is the purpose of doing this? What is the purpose of getting into every detail, every feature, and putting these cancers in very low, favorable intermediate, unfavorable intermediate, high risk, very high risk? What is the purpose? The purpose is that we want to individualize treatments. So two patients might both have the same T stage. Is their prognosis the same? No, based on other factors. So the more factors, the more features we use, and the more fine-tuning or fine stratification we do in terms of risk groups, the more specific we can be in terms of if the patient has a very low risk prostate cancer, does he really need all the treatments that we are offering? Are the treatments recommended to someone with very low risk versus somebody with unfavorable intermediate risk versus somebody with very high risk group prostate cancer? Are they going to be the same? No. And that's the point. We want to be very specific about what we recommend to each one of these risk groups. So the next thing that I want to discuss today is what is usually used in treatment of prostate cancer. This is a statistical predictive manner of making an educated guess on certain things, such as like what is the risk that this patient has lymph node involvement without actually going and removing the lymph nodes. Can we create a nomogram that with some degree of accuracy can predict what is the risk of extracapsular extension? What is the risk of seminal vesicles being involved? And thankfully, we do have multiple nomograms. I would be discussing 3 of them with you today. The first nomogram is called Brigante, and it basically shows or predicts percentage of lymph node involvement. Why does it matter? Well, when a surgeon wants to do surgery, or when radiation therapist wants to give radiation, the surgeon wants to know whether, in addition to removing the prostate, whether they need to remove some lymph nodes to see whether there's cancer in it or not. A radiation oncologist like me may want to know, do I need to just target prostate? Do I need to target lymph nodes? This is when these statistical predictions helps a radiation oncologist or a urologist to kind of decide for each individual to what degree they need surgery, to what degree they need radiation. So these nomograms are online, and I would put a link in YouTube where you can go and actually try them for yourself if you want. But for each one of these nomograms, you need to have a set of information that it's going to ask you to enter before it gives you a number. So for Brigante, information I or you need is preoperative PSA. We need to know T stage. We need to know Gleason grade group, as we discussed. It could be 1, 2, 3, 4, 5. We also need to know percentage of positive biopsy cores with highest grade PSA, prostate cancer, or percentage of positive cores with lowest grade prostate cancer. So you want to, in addition to knowing Gleason grade group, because it is important to mention that cancers are not really what we call homogeneous, meaning that just because somebody has been assigned a Gleason score of, say, 7, doesn't mean that every core every piece of tissue that has been removed has a Gleason score of 7. We usually go with the highest Gleason score. So somebody might have 12 core biopsies and one of them might have Gleason score of 6. 2 of them might have Gleason score of 3 plus 4, 7. One of them could have Gleason score of 4 plus 3, 7. And we go with highest Gleason score, which is 4 plus 3, 7. So you enter the highest Gleason grade group in one of the questions. And then it asks you, what is the percentage of positive cores with highest grade? What is the percentage of positive cores with lowest grade? And when you enter all this information in this nomogram, then it would give you a number that is an educated guesstimate of what is the possibility that the lymph nodes are involved. Now, if the possibility is 7% or less, a surgeon would not do a pelvic lymph node dissection, or a radiation oncologist would not target lymph nodes in the pelvis with radiation. Because in everything that we do or recommend, the benefits have to outweigh the risks. And when you have risk of pelvic lymph node involvement that is 7% or lower, that means that the side effects of doing a pelvic lymph node dissection would outweigh the chance of finding a positive lymph node. And for that reason, we would not do that. The second nomogram that we'll be discussing today is from Memorial Sloan Kettering Cancer Center. And what it does, first by asking a couple of questions about hormonal therapy and radiation therapy, it would remove patients who disqualify for Memorial Sloan Kettering Cancer Center. Once they qualify, then it would ask you, you have to have this information, age of the patient, PSA before biopsy was done, Gleason score, you need to know the primary pattern, you need to know the secondary pattern, and the nomogram automatically calculates the total Gleason score. You need to know the T stage, you need to have percentage of positive cores, percentage of negative cores, and the nomogram automatically calculates the percentage of, you need to know number of positive cores and number of negative cores. And nomograph calculates the percentage of positive cores. What information MSKCC nomogram is going to give you is going to give you an estimated guess of life expectancy, and is going to give you an educated guesstimate or estimate of risk of dying, specifically from prostate cancer. The third one is Parting nomogram from Johns Hopkins. And what the information it needs PSA, it needs T stage, and it needs Gleason score. And information it gives you, it would give you percentage of possibility of cancer being confined to the prostate. It can give you percentage of risk of having extracapsular extension. It can have you percentage of possibility of involvement of seminal vesicles, and it can give you percentage of possibility of having lymph nodes involved. So these were nomograms, and as I said, I'll put a link and you can play with them and see how the numbers change. Now, the last thing that today I would like to discuss is what is called tumor-based molecular assays. Now we are getting into biology of tumor. So you might have cancer, 2 people that have exact T stage, the same, their Gleason score is the same. Even the risk group we have put them in could be the same. But when we do a biological molecular assay of the tumor itself, we get additional information, that then may put these two people with exact same T stage, exact risk group into two different categories in terms of what treatment we are recommending to them. So one thing that I want to clarify, first of all, is the name of these tests. 3 of them, they're called Decipher, Polaris, and Oncotype DX. Now, neither of these tests are being used in the extremes of the risk groups. We don't use it for very low risk group. We don't use it for very high risk group. So we use them for these stages in between. Now, for 2 of these tests, specifically Decipher and Polaris, they can be used for all the other categories, meaning low risk, favorable intermediate risk, unfavorable risk, and high risk. So we excluded 2 of the 6 risk groups. For the remaining 4, Decipher and Polaris can be used. Oncotype DX can only be used for low risk and favorable intermediate risk. It cannot be used for unfavorable or high risk group. Now, what information are these tests are going to give us? All these 3 tests would give us the risk of distant metastasis after a radical prostatectomy. Oncotype does, Decipher does, and Polaris does. When it comes to prostate cancer specific mortality after radical prostatectomy, Polaris would not give you that information. You can get that information only from Oncotype or Decipher. When it comes to prostate cancer mortality after adjuvant treatments, then the only test that would help you is Polaris. The other 2, Decipher and Oncotype, would not give you that information. When it comes to what is called biochemical recurrence, let me first define that for you. So if a patient has the prostate removed or had radiation, one of the ways that we monitor their course of follow-up is by checking their PSA periodically. Now, if their PSA drops to the lowest possible, and it's like that for 2 years, and then suddenly PSA starts creeping up and start rising, we call that biochemical recurrence, meaning a recurrence of prostate cancer that has been detected solely on PSA. Now, 2 of these tests can give us a number predicting a risk of biochemical recurrence, and those are Oncotype and Polaris. Decipher would not do that. And then if you did the test prior to a prostatectomy, so based on the tissue obtained from biopsy, Oncotype and Decipher can also give you a number predicting the risk of having adverse pathology if the patient did a prostatectomy. Polaris would not give you that information. So with the exception of metastasis, distant metastasis after radical prostatectomy, each one of these tests offer a certain number of information, but not all of them give you all of that information. Now, so what can you expect when you do one of these tests? What does the test result look like? So for Decipher, if you can do it after biopsy, you can do it after prostatectomy. So depending on the tissue that has been given for the Decipher test, if it is a biopsy or it's after prostatectomy, these 3 information will be given for both of them, regardless of whether you did the test on the tissue from biopsy or you did it on the tissue from radical prostatectomy. It gives you percentage of distant metastasis at 5 and 10 years. It also gives you percentage of risk of dying from prostate cancer specifically at 15 years. So you can get this information either from the biopsy or from the radical prostatectomy. The only additional information that you would get from doing this test on biopsy, it would also give a prediction of what is the possibility that if the patient did a prostatectomy, is going to have adverse pathology. And why does it matter? Why do we need a prediction of what is the percentage of having adverse pathology if the patient chose radical prostatectomy? This is the reason. Each treatment modality has its own profile of side effects. For that reason, if we can avoid, we would like to give one treatment rather than 2 or 3, right? Because if we offer you 3 treatments combined, you're going to experience side effects of all of those treatments. But if we just offered one treatment based on this stratification and said the best treatment for you is this, then you're subjecting yourself to only profile of side effects of that particular treatment. So if a patient chooses prostatectomy and they have adverse pathology, meaning that risk factors that are detected on the pathology report after prostatectomy, then we may have to recommend radiation therapy, we may have to recommend hormonal therapy, depending on adverse pathology. So now patient has undergone surgery, on top of it has to get radiation, sometimes on top of it has to get hormonal therapy. Now, if we had a test that could predict with some degree of validity, accuracy, that the risk of adverse pathology in this patient is really high, then why would we subject that patient to prostatectomy? If we already know with a very good likelihood this patient is going to have adverse pathology, would probably need radiation and hormonal therapy on top of surgery, then we would just say no surgery, let's just do radiation to spare them from the side effects of surgery. That is the reason that these molecular assays are helpful in giving us the educated guess that what is the possibility of having adverse pathology if the patient had a radical prostatectomy. Now, for Polaris, it would give us disease-specific mortality with surveillance, and I will talk about it more, and also percentage of having distant metastasis after radiation or radical prostatectomy. What is surveillance? Surveillance is a treatment that may be offered to very low risk and low risk group patients with prostate cancer, and basically involves a very close observation, not only by doing frequent PSAs, but also MRIs, biopsy of prostate more than once, to basically keep an eye on a very low risk or low risk prostate cancer. And some percentage of those never go to a higher grade or higher risk group, and we just can keep watching the patient without giving them surgery or hormonal therapy or radiation therapy. And if during course of surveillance, the cancer was upgraded to a higher Gleason score or it was upgraded to a higher stage, then at that point, we may offer them treatments. So by using Polaris only, we have been able to decrease percentage of surgeries by 34 to 50%. That is in people who have done Pilates. And decrease the use of radiation therapy by 30 to 40%, which is huge. We have been able to double the possibility of active surveillance. And we also have been more than doubling predictive value of disease-specific mortality. And because of this, we have been able to decrease costs in healthcare, because if a patient can be just treated with radiation and no surgery, or just surgery, no radiation, we have decreased costs for the patient and also for the healthcare plans. Oncotype DX really shows us correlation of the tumor with its aggressiveness. And we discussed about prostate cancer specific mortality after radical prostatectomy, biochemical recurrence, and also adverse pathology. So in summary, we use all of these, T-staging, nomograms, molecular assays, categories of risk groups, really to tailor specific treatment to specific patients, to specific cancers with their different biology. So it's not like one fits all. Somebody enters the door and they have prostate cancer, you get this, this, this. It's not like that. By using this statistical methods, molecular assays, risk factors that we have learned from decades of research on prostate cancer, we can fine-tune and tailor specific treatment for specific individuals and individual tumors. That is really called individualized therapy. For that reason, if you or someone, loved one or friend or whoever has prostate cancer, you have to be aware that you're talking about apples and oranges. A prostate cancer that belongs to a very low risk group is a completely different animal from prostate cancer that belongs to the very high risk group. For that reason, treatments offered are different. For that reason, prognosis is different. So even though it might be sometimes helpful to speak to somebody who has had prostate cancer and can share their experiences with the treatment they received, that might be helpful, but you should never make decision about your treatment or treatment of your loved one based on someone else's experience. Because we put all of these very low risk, favorable intermediate, unfavorable intermediate, high risk, very high, we all put them under one umbrella called prostate cancer. But these are different diseases. These are absolutely different diseases, different degrees of aggressiveness, different needs for different treatments, sometimes no treatment. Active surveillance would be an option for some people. So it is very important that your doctor uses all the tools to really, really fine-tune the treatment based on your individual or your loved one's individual risk group. I hope this has been helpful. In the next session, we start moving into the actual treatment options and recommendations based on different risk groups. Thank you.